at the Crane Center for Early Childhood Research and Policy, that very long name shortened to CCEC. And on behalf of CCEC, I'd like to welcome you all to the first of our First Friday Colloquia series. We're really excited about it. And mostly we're excited about it because one of our key missions at the CCEC is to have a formal place or format to share our expertise in child development and early educational experiences, and to really connect with our university community and have a spot where we can be informal and collegial and have some great discussions. So we're hoping that this First Friday Colloquia series will be that for us. So we're really pleased to have you all here for our first discussion. So please join us every first Friday of the month for pizza and for hopefully some really good, rich discussion. Okay, so for our first of these, we are very, very pleased to have Dr. Carolyn Gunther. She is an assistant professor in the Department of Human Sciences, a clinical assistant professor in pediatrics, and an adjunct assistant professor in animal sciences. Her research program focuses on developing and testing community-based family nutrition interventions to improve the food choices and eating behaviors of young children, and then to ultimately reduce the incidence of childhood obesity. So without further ado, I will let Carolyn take the stage. Thanks.
Thank you, Dr. Cameron. Do I have to turn this on, or am I'm good to go? All right, we are ready to rock and roll. All right, thank you, Jill, for your warm introduction. It's my pleasure and honor to be here for the inaugural meeting of the Crane Center's seminar series. This is really exciting for me and you. Hey, Laura. So I'm here today to talk about the role of food choices and eating behaviors in kids' diet and health and well-being. And I know what binds all of us, the common factor that binds all of us is our interest in early childhood development. And so, but I'm pretty sure that there's only a small group of nutritionists in that group. So that's the case, and they're right over there. My team is right over there. So I've tried my best to craft this discussion to get all of you with that awareness that you don't have a nutrition and obesity background. I did my training at Purdue University in adult obesity treatment and prevention efforts through primarily through diet interventions. And now in my career at Ohio State, I'm interested in pediatric obesity prevention. Okay, so as I said, the tie that binds us is our interest in early childhood development. And I'm making the assumption because we're all living in the United States, even though you don't have a nutrition background and you're not specifically studying childhood obesity prevention, that you're all keenly aware of the problem of childhood obesity in the US today. So you would have to really be living in a vacuum not to be aware of what a serious problem it is. So in all the readings that I've done, I don't think there's any quote that really better represents or the seriousness of the problem of childhood obesity in the US today than the Surgeon General's recent quote in her vision for a fit and healthy nation. So she says here that today's epidemic of overweight and obesity threatens the historic progress we've made in increasing Americans' quality and years of healthy life. She says here that 2/3 of adults and 1 in 3 kids are overweight or obese, and the sobering impact of these numbers is reflected in the nation's concurrent epidemics of diabetes, heart disease, all these chronic illnesses. So they're occurring together, the incidence of obesity and chronic illnesses in the US. She says here that if we don't put a stop to these trends, that our kids, our most precious resource, will be afflicted in early adulthood with these serious illnesses, okay? And she concludes by saying that this future is simply unacceptable. So this is a quote that I like to sort of put forward, right out up front to just put some weight to the seriousness of the problem of childhood obesity. Okay, so on this next slide here, we're simply looking at the statistics that back the Surgeon General's warning, okay? So over the past 3 decades, or the past 30 years, we've seen a significant rise in the rate of childhood obesity among all age groups of kids, okay, even our youngest. So this disease of obesity does not discriminate with regards to age. Even our youngest kids, our preschoolers, our toddlers, and some infants are being affected by the problem of carrying excess weight, and specifically adiposity or fat mass. Okay, so again, we're looking at a near tripling in the rate of obesity among young kids and adolescents over the past 30 years. This disease does discriminate, though, with regards to race and ethnicity. And I don't have that data here, but there's a disproportionate increase or risk that's experienced by those individuals from racial minority backgrounds. So African American kids and Hispanic kids are at a much higher risk for becoming obese than their white counterparts, okay? There's new data that's not shown here on this graph, but there has been a report made by CDC in the last year that there's been a leveling off or a plateau of these numbers, which is good news. It's indication that all of these efforts, these programmatic efforts, policy efforts that are being invested in the problem of childhood obesity are resulting in at least a leveling off of numbers, okay? But even at a rate of 30%, okay, 30% of our kids, even at that rate, it's too high. It's still a problem. There was a report in the literally in the last month that preschoolers, and that's what our group studies, that age group, there's been a drop in the rate of obesity among preschoolers. So that's age 2 or 3 to 5 years old. So that's good news. The CDC, when they released this report, they released it by state, and Ohio did not make the list. So we still have a serious problem in the state of Ohio. We have a lot of work to do. Okay, so the next question that I like to pose to students and myself, why do we care about this problem? Does it really matter that people, our kids, are carrying around excess weight? And when I talk about weight, I'm talking specifically about body fat mass. Well, it matters. The consequences of excess weight, carrying around excess weight in childhood and adulthood, are serious and they're widespread, okay? And so what I'm showing here is first the health risks. These are the health risks or consequences that result from childhood obesity. The risks occur in childhood. We see kids now in clinic who have high blood pressure, high cholesterol, problems with their glucose metabolism, insulin resistance, the list goes on. Okay, so that is relatively new data. The kids are becoming sick clinically in childhood. Okay, and we also know that kids who are overweight also have an increased risk for becoming overweight and obese into adulthood, okay? And that, of course, as we know, leads to all sorts of chronic illness, such as heart disease, diabetes, and some cancers. And this is really just, a snapshot. There's data indicating that there's a multitude of other health risks that are consequences of childhood obesity. Okay, there's negative social and psychological effects. Kids who carry excess weight in childhood through adulthood experience low self-esteem. They're at a higher risk for dealing with discrimination in the school setting. And kids who are overweight are also at a much higher risk for depression and suicide and other related things, okay? This is of interest to many of you in the room, and you're probably aware of this association that's been made. Kids who carry excess weight are underperforming in the classroom. Okay, so there's been a relationship, at least in a correlational sense, that kids who are overweight don't perform as well academically. Okay, so there's a real dearth of information in that particular area of scholarship, which presents a real opportunity for us in this room to address. Okay, and then there's also the economic burden that results from childhood obesity. There's been a near tripling of obesity-related healthcare costs just in kids alone in the last 3 decades. So we talked about a 30% increase in the rate of obese kids and adolescents over the last 3 years. well, we've seen healthcare costs in kids parallel that statistic. Okay, so the bottom line take-home message from this slide is that there's many reasons to care. Why, our kids today, many of them, why they're overweight. The consequences are grave and they're widespread. It's not just health that's affected, but all sorts of other aspects of childhood health and development. Okay, so next I'd like to begin talking about, what are the causes of obesity. So we've known for some time that it's a multifactorial problem, okay, so that's been clear. This framework here, this theoretical model that I'm showing you here, the social ecological framework, is really the model that's, or mechanism that's being most used, at least in our field of community nutrition. And this really points to the complicated nature of the problem. And it also, for those of us in the field, it presents a great tool for developing interventions. Okay, so here we can see that a child's risk for becoming obese is affected by multiple factors, genetic factors and behavioral factors at the individual and family level. A child's risk for obesity is also influenced by various behavioral contextual settings. So the home environment, the school environment, the community environment, the work environment, all of these settings in which a child lives affects his or her risk for becoming obese. Policy at these various sectors of influence also influence a child's risk for becoming obese. And then of course, at the outer ring here, we can see that society's rules that guide individuals and groups' attitudes, beliefs, and behaviors influence risk for obesity. So simply put, it's a complicated problem. A child's risk for becoming obese is influenced by multiple factors at these multiple layers of influence. I like many things about this particular theoretical framework for understanding the causes of obesity, but one thing I like about this is that it really points to the importance of conducting multi and cross-disciplinary research. If we're not communicating with each other in a real, meaningful, active kind of way, we have no chance at solving this problem. Okay, so I want to sort of shift gears right now. I've hopefully really set the tone for the problem of childhood obesity. Why do we care? What are the consequences? What are the causes? And I want to shift now to talk about what my research group is really interested in, specifically interested in. And in our group, we're really interested in studying the individual and family factors related to diet and a little bit of exercise. But we are nutritionists, and we're interested in dietary behaviors. We're interested in studying those factors, how they influence a child's risk for becoming overweight and or obese. And we do our work in a couple of behavioral settings. So we're interested in intervening in the daycare. Most kids these days, as you know, are enrolled in some sort of child care program. And so there's real intentionality to why we've decided to make that our site of intervention. I've listed home here because we're really interested in, if we use the daycare setting as our site of intervention, how do those intervention effects carry over into the home food environment? Okay, so that's an area of research that we're also interested in. Okay, so let's talk a little bit about, I've mentioned that there are dietary behaviors, okay? Diet behaviors, other lifestyle behaviors that influence a child's risk for becoming obese. So what are those behaviors? Well, we know what they are. This is a really wonderful article that came out in 2009 that clearly delineates what those modifiable dietary behaviors are that relate to key dietary determinants and in effect influence a child's weight status. And part of the reason why I'm going to walk you through each of these is because each of these behaviors are incorporated into our intervention, okay? So at the child level, it's been clearly identified that a child who has, meets the recommendation for fruit and vegetable intake, who eats ready-to-eat cereals, has a nutrient-dense, low-fat diet, has regular breakfast, drinks milk, eats beans, limits eating out at fast food restaurants, is a picky eater, that's a negative determinant. I've moved now from positive to negative determinants. A child who drinks soda is at an increased risk. A child who skips breakfast is at an increased risk for obesity. And a child who has poor snacking behaviors is at an increased risk for developing or acquiring excess weight. Okay, so all of these behaviors are on the child level. On the parent or family level, we've identified that parents who model healthy eating behaviors have a better chance of having a child who's at a healthy weight. Availability of healthy foods at the home and in the meals is another positive determinant of healthy weight status. Preparing healthy foods in the home, planning meals, and family meals. Okay, so again, these are based on the current literature. These are the modifiable dietary behaviors that have been associated with determining a child's weight status, okay? And these are points of interest in the work that we do. Okay, so around the same time, and this was not coincidental, the American Academy of Pediatrics Expert Committee for the Prevention and Treatment of Childhood Obesity came out with a short list of evidence-based dietary recommendations that clinicians could use in their practice. Okay, so these included things like encouraging consumption of fruits and vegetables, limiting sugar-sweetened beverages, eating breakfast daily, limiting eating out at restaurants, encouraging family meals, and limiting portion sizes. Okay, so these recommendations, again, that were established by the American Academy of Pediatric Expert Committee for the Prevention and Treatment of Childhood Obesity came out right around the same time that this article came out, okay? So this was great news for us in the nutrition field because it really gave us a guide in our intervention work. Okay, so we've talked about the dietary behaviors that we know relate to a child's weight status. Okay, we've talked about what those are at the child level, at the parent level, and at the family level. Okay, let's talk now a little bit about when and how eating behaviors are laid down in life. And we know from the literature that it's during those early years that kids develop their food choices and eating behaviors, okay? And our group is particularly interested in the preschool age time in life because it's during that time that a child moves away from a primarily milk-based diet to adopting the eating behaviors of the family, okay? So simply put, we're moving away from the breast to the table. And so that in essence makes it nutritionally a critical window of time. And so that's why in particular, why we're interested in the preschooler age child. And we know that those eating behaviors that are laid down during that period persist through a lifetime. Okay, so how are they laid down? We also know that parents play a major role in the foods that a child eats and in the type of eating behaviors that they engage in. There have been key parent practices that have been identified, and those include things like making healthy foods available, setting expectations for intake of healthy foods, and I've listed here role modeling. So when you're talking about a child who's 3 to 5 years old, they are, for intuitive reasons, they are really dependent in large part, in most part, on the adults around them. Okay, so parents play a major role as the nutritional gatekeepers of the home. Okay, so we also know that, eating behaviors are laid down early in life. We know that parents play a major role. We also know that parents face multiple barriers to establishing these healthy eating behaviors for their families. And I've listed here what we know from the literature. First is a lack of nutrition knowledge. So they don't know what the recommendations are. What is a healthy diet for a child and for a family? We also know that parents lack food preparation and cooking skills. So this is an art. Cooking as an art and a skill is something that's been lost in the 21st century. Parents deal with food acceptance issues. So preschoolers by nature deal with issues such as neophobia or fear of new foods. They're also classified, and this is really just a developmental artifact, but they're classified as picky eaters. So preschoolers by nature deal with food acceptance issues of new foods and then also commonly consumed foods. Time and budget limitations is another major barrier that parents face in establishing healthy eating behaviors for their families, and also lack of social support. So we know this based on the literature, that these are the barriers that parents face in establishing a healthy food and eating environment for their kids. So we also know that there are some real commonalities among the successful efforts. So there's been plenty of efforts, programmatic efforts, as they relate to nutrition to solve the problem of childhood obesity. Okay, so there's no limit to the number of efforts that have been made. But if we look at the commonality among the successful efforts, we know that all successful efforts have relied on some sort of theoretical framework in their intervention. Okay, we also know that there has to be at least either direct or indirect engagement of parents in order to get kids' diets better and get them on a healthy weight gain trajectory. We also know that multi-component strategies work better than singular component strategies, and that could sort of play out in a variety of different ways. But for example, it's interventions that combine education efforts with skill building efforts tend to be more successful than education efforts alone. Okay, documentation of behavior change is another commonality among the few successful efforts, and then follow-up in a clinical or daycare kind of setting. So you need to get kids and families into some sort of community setting in order to interact with them and document the behavior changes. Okay, so I wanted to present to you one example of a successful intervention targeted to kids. These were older kids, but this was a study conducted by Jane Fulkerson, who's at University of Minnesota, and she's a nursing faculty there. And in 2010, she had been working on this project for a while, but in 2010, her paper came out, and I presented that to you here. So the title of her intervention was the Healthy Home Offerings via the Mealtime Environment Study. Okay, this was a randomized controlled trial. It was a pilot childhood obesity prevention intervention, community-based. They relied on the social cognitive theory of behavioral change for their theoretical framework. This was a community-based intervention, as I mentioned, that involved both parents and kids. She was interested in the pre-adolescent period of life, 8 to 10 years old. The educational sessions were, she delivered 5 of those. They were 90-minute sessions and delivered over a 3-month period of time. The sessions included nutrition education, testing, cooking, and parent discussion groups. And this was a pre-post test design. And they not only did pre-post testing, but they also did a 6-month follow-up test to determine if there was any retention of changed behavior. Okay, so this is, again, one example of a successful effort that incorporated all of those commonalities that we talked about in the previous slide. So what they found was in kids who were enrolled in the intervention group that they had a significantly higher intake of fruits and vegetables. They also had a significantly lower intake of sugar-sweetened beverages. They also saw an increased level of dietary fiber as compared to the control group. And that, of course, would be in correlation with consumption of fruits and vegetable intake. And then they also saw an increase in calcium intake. So kids enrolled, randomized to the intervention group, had a significantly higher calcium intake versus the control group. Okay, so Jane's study really was another piece of evidence, pointing to the importance of including all of these components to interventions, childhood obesity prevention interventions. So that's theoretical framework to the intervention, direct. In her case, they engaged parents directly and found that that was successful. The multi-component strategy is important, documentation of behavior change, and again, follow-up and delivery in a clinical or daycare kind of setting. So I just wanted to refresh your memory. These are the commonalities among successful efforts. And I would argue, based on the literature, that we need to add to this list early intervention, knowing that kids lay down those eating behaviors early in life, they persist through a lifetime, that our best bet is to intervene early, particularly during those preschool years when kids are establishing their food choices and eating behaviors that will persist through a lifetime. Okay, so that was all the work, setting the framework for why it is that we're here today. So here comes the fun part. So this leads me to our study hypotheses. So based on what we know, based on the gaps in the literature, this is what we hypothesize, that participation in a daycare-based nutrition, education, and cooking program aimed at parents and their preschool kids, aimed to teach them positive eating behaviors, will lead to these improvements. On the child level, we hypothesize that participation in this program would lead to improvements in food preparation skills and also an improvement in diet quality. We were particularly interested in, based on the evidence, fruit and vegetable intake, high-fat foods, high-sugar foods, and also high-fat or high-sugar beverages. We're also interested in parent self-efficacy, or confidence in establishing healthy food and eating behaviors for their families, and frequency of family meals prepared at home. Okay, so based on those hypotheses, our objective was to develop and test feasibility, acceptability, and potential efficacy of a blended nutrition, education, and cooking program aimed at teaching parents and their preschool-age kids positive eating behaviors. Okay, our aims were, number one, to develop and implement a nutrition, education, and food preparation cooking program targeted to parents and young kids. And number two, to evaluate potential efficacy of participation in this program on improvements in child and parent food choices and eating behaviors. And we outlined those on the previous slide, those particular eating behaviors that we were interested in. So before we set out to design and implement our intervention, the first thing that we did was conduct a needs assessment study. So we were really interested in knowing, we asked a lot of different questions, but here I'm just going to focus on the family meals data. But the aim of the needs assessment essentially was to understand the value that families place on family meals, the challenges that they face in establishing regular family mealtime, and topics of interest. So we asked parents, if we were to come to your daycare and offer a nutrition, education, and cooking program for families, what sort of topics would you be interested in seeing? So our sample here was parents with young kids who were enrolled at the Schoenbaum Family Center. We had a sample size of 16, so this was a 17% response rate. The survey, on this quick survey, we asked several questions related to our aims. The first was we asked parents to rate their level of importance of preparing and sharing family meals. We asked them in an open-ended question challenges that they faced in establishing regular family mealtime. And next, we again asked them in an open-ended question what sort of topics they'd like to see in such a program. Okay, so here's some data from the needs assessment study. So interestingly, we found that the large majority of parents placed a high value on family meals. Okay, so it's something that they identified as being important to them, an important routine or ritual of the family. Almost all parents, 15 out of 16, reported at least one barrier to regular family mealtime. Time barrier was the biggest barrier of all, followed by having a lack of ideas, recipe ideas, and then meeting the family needs or the different preferences of the family. So you've got one kid asking for this, another kid asking for that, okay? Parents were very quick to share ideas that they would like to see in a potential program like this, and I've listed those here. They included ideas for preparing quick, healthy meals that are also affordable, how to involve their child in meal preparation, and then recipes that might be not only quick, healthy, and affordable, but also appealing to a child. So the bottom line finding from this needs assessment study was that parents place a high value on family meals, number one. Number two, they're having trouble getting it done. They're not able to establish that routine within their family on a regular basis due to these multiple barriers, and they provided really excellent feedback in what sort of topics they would like to see. And so results from this needs assessment survey in part informed the design of the curriculum itself. Okay, and so on this next slide here, I'm showing you a little bit of information that went into the design of the curriculum. So again, we used data from the needs assessment survey. We also relied heavily on national dietary guidelines. Okay, so the 2010 US dietary guidelines, the messaging that's incorporated in those guidelines really heavily informed the design of our curriculum. We also included the behavioral targets that are included in the American Academy of Pediatric Expert Committee guidelines, and we looked at those previously. And then we also worked from 2 existing curricula and took what I call lessons learned from those existing curricula. These are curricula that have been tested in the community, not just in Columbus, but nationally. The first of these is the Happy, Healthy Preschoolers program. The brainchild for that curriculum is sitting here in the room, Dr. Murray, and actually Kelly was part of that as well. So the 2 of them are here today. So that was a previously tested curriculum for parents of preschoolers, and it was a community-based nutrition physical activity program, again, for parents of preschoolers, particularly low-income preschoolers. So we worked from that curriculum and the design of our new curriculum, and then we also worked from the expanded food and nutrition education program, which is essentially a federal nutrition education program for families with kids of all ages. Okay, so there were a lot of various inputs into the design of our curriculum. Okay, so the theoretical framework for our intervention, like Jane Fulkerson's and most other community-based nutrition interventions going on, was the social cognitive theory of behavior change. And this theoretical model asserts that behavior, an individual's behavior or behavior change, is really the result of a reciprocal relationship between various personal factors and external or environmental factors. So some personal factors include knowledge, skills. So these are the resources that an individual needs in order to make a behavioral change. Self-efficacy or confidence in one's ability to make behavior change is another important personal factor that influences behavior change. And then outcome expectancies, which is essentially the value or benefit that an individual expects to receive by engaging in that target behavior, is another personal factor that influences behavior change. External or environmental factors, when you're talking about parents as the proxy of a child, are the 2 critical external factors are role modeling and availability, meaning making healthy foods available. Okay, so again, this is the theoretical framework for our intervention. And one important note here is that all of these factors that I've listed here, the personal and external factors, are dependent on an individual's ability to self-control or self-regulate one's behavior. And we know that there's a lot of literature pointing to the fact that when an individual engages in the act of goal setting and goal monitoring, that is sort of a mechanism for increasing at least their perception of self-control. Okay, so this again was the theoretical framework of our intervention. Okay, so our intervention was a multi-component intervention. We involved nutrition, education, and activities. Those were developed as a part of the program. These occurred separately for kids and parents. We also had skill building and food preparation and cooking. Goal setting was part of the program for the parents. Of course, kids are too young, cognitively to engage in that activity. Family meal preparation. So our program occurred over the dinner hour, which gave parents and kids the opportunity to prepare a meal and partake in the meal. We had take-home educational materials and then session evaluation. So these were all of the components that were a part of each program session. We developed and implemented 10 programs. Each were 90 minutes in length. These occurred on a monthly basis over the academic year from September to June. And again, as I mentioned, the program was delivered over the dinner hour, and there was real, of course, intentionality in designing the intervention in that way. Okay, so this is probably familiar to most of you in the room, but we've done all of our pilot testing over the last 3 years at the Schoenbaum Family Center, which, as you know, is an EHE, or our college EHE affiliated research or lab school. Okay, this is the center is located in Wineland Park, which, as you know, is juxtaposed to the university. It's a extraordinarily low-income area within the Columbus area, and the center itself draws a mixed population. So at the time of the data that I'm presenting now, there was an equal mix of individuals or families from low-income and non-low-income backgrounds, which in a research sense does present some logistical problems. Okay, so our staffing structure, let's talk a little bit about that. So we relied on 2 Schoenbaum family preschool teachers. Okay, those individuals were responsible for the activities that were involving the child alone, separate from the parents. We had honors undergraduate students helping out with teaching and program preparations. As part of our staffing structure, we rely heavily on the dietetic interns. So at Ohio State, there are 2 dietetic internship programs, and one of those is housed in the Department of Human Sciences. And those individuals who have their BS are in a year-long training program in our department, and as part of that internship are required to gain real-life practical field experiences. And so this has ended up being a really wonderful provision in our programming, and also a provision or in their training. So our target audience was families with young kids enrolled at the Schoenbaum Family Center, and we had both low and non-low income households. Okay, so here I'm showing you a listing of our process outcomes. To assess program feasibility, we measured attendance. To assess program acceptability, we measured that via a parent and child satisfaction tool. And then we developed a program-specific tool that assessed intervention fidelity. Okay, so these were our 3 process outcomes. On this next slide, I'm showing you our study outcomes, our behavioral outcomes. So I'll just mention before we go into those that this again was a pre-post test design. We collected data at baseline, midway through the project, and at the project end. On the child level, we collected data on their food preparation and cooking skills. We also collected dietary data on kids that were enrolled in this project. And on the parent level, we measured their self-efficacy for making healthful changes in the home. And then we also measured with a validated tool frequency of family meals. Okay, so we're moving into results here. So in this next slide, I'm showing you the 10 lessons that were developed as part of our intervention. And you can see the titles for each of these here, and the programmatic, or I should say behavioral targets for each of these. Our topics ranged from helping parents understand the value of family meals, and then really in the next portion of our program, we focused on essentially food groups from fruits and vegetables, whole grains, calcium, protein, fat, And then we finished off with sort of special topics. One was included a focus on having regular breakfast, decreasing salt intake, which is a new old message that's coming out in the National Dietary Guidelines. We had a whole session developed or dedicated to healthy snacks. And then we had another session that was focused on pleasing picky eaters. So this gives you sort of a flavor for the program topics and, again, the behavioral targets. Okay, so here I'm showing you greater detail from one of the lessons, and this one in particular was focused on building strong bones. So from a dietary perspective, we were interested in helping parents and kids increase their intake of calcium-rich foods and beverages, particularly from dairy sources. Okay, so I've listed here some of the specific aims, and these look similar for each of the lessons, but we first start out by introducing the benefits of calcium-rich foods and beverages, or whatever topic it is that we were talking about on that night for the other lessons. And then we essentially help them gain knowledge on, what are good non-dairy and dairy sources of calcium, what are their recommendations for them. We help kids learn those recommendations specific for preschoolers, and then we move into a section where we teach parents, work with them to develop effective ways for establishing the target behavior. So easy ways to incorporate calcium-rich foods and beverages into kids' diets. And then we finish off by working with parents to help them set goals to reach the recommendation. And here I've also included a menu for that night, which was spinach salad, whole wheat pizza, and banana pudding with wafers. So, right. Now, I'm a calcium researcher by training, so there was real intentionality as we were very careful about synchronizing, the menus, the recipes with the topic of the night. So for a vegetable food source, spinach has a high calcium intake. Of course, the pizza had cheese, and then the pudding was made with milk. So anyway, so that was something that was taken into consideration in the design of our program. Okay, so we experienced high program feasibility with this study, and that's one of the main selling points, I think, of the work that we do. So we consented 11 families, 10 completed, and that translated into a 91% retention rate, which is very high for community-based programming. We can talk about later why that might be, and this was intentional in the design of our program too, but this is an incredibly difficult population to reach. Parents, families of preschoolers, they've got every kind of demand on them, but we heavily, throughout the program, incentivization was a real consideration. So having a meal and giving families, bags of groceries with ingredients of foods that we made that night, all of those kinds of incentives that were woven into the program itself may help explain the high retention rate. Our average attendance rate, so of the consented families, our average attendance rate over the year's time was 45%, and that ranged from 45 to 100%. So we actually had, if you look at total attendance for each program over the year's time, we had an average attendance rate of 10 to 15 families. It's just not all of them were consented to participate in the research. Okay, so here we're looking at program satisfaction. You remember the primary aim of this project was feasibility and acceptability, to test those two factors in this pilot test. We experienced high feasibility. We saw that on the last slide, and here we're looking at the satisfaction data. So all of our parents reported high or very high satisfaction with the program, and all reported that their parents enjoyed the program. So that's a flavor of the satisfaction data. And here we're looking at our participant characteristics by income status. So I mentioned to you that we recruited families who had children enrolled at the Schoenbaum Family Center, which is by nature, by definition, a mixed income population. And so we had 11 families consented, and they were split equally, and this was unintentional. I mean, we opened up invitation to participate in the study to everyone who had children enrolled in the center, but we ended up with a equally mixed income group. So the majority of our low-income parents were younger, they were less educated, and they were primarily African American as compared to their non-low-income counterparts. The majority of our kids were in the 3 to 4 year age group. We did have some kids below the technical or preschool age definition. We had a couple of, or a handful, 4 in the 1 to 2 year old age group. And this is sort of messed up here, but the sex of the children was equal between groups, and then we also had an equal proportion of male and female children participants. Okay, so here we're looking at, I'm just going to zoom out for a second. You remember that we had behavioral targets or outcome measures on multiple levels, on the child level, on the family level, and then also on the home level, okay? So on the child level, again, we were interested in a couple of things. First of all, improvements, we were interested in food preparation and cooking skills in kids, and we were also interested in their diet itself, okay? So here we're looking at results of food preparation skills, and you can see here that adjusted for potential confounders, which included baseline age of child, baseline BMI of child, and family economic status, we saw a significant increase in children's ability to rinse fruits and vegetables, and we saw an increase in children's ability to help assemble foods. We'll talk about this later, but this is pretty, these are pretty weak, modest findings, but regardless, we did see a couple of positive outcomes of the intervention itself as it related to food preparation skills of kids. Okay, so here we're looking at the dietary data. So again, adjusted for the potential confounders, which in this study included baseline age of child, baseline BMI, and economic status of families. We saw a significant increase in fruit and vegetable intake of kids. And we also saw, and that was from midway through the project to the end of the project. We also saw a significant reduction in sugar-sweetened beverage intake, although this positive change did not persist to the end of the study. It washed out in the end when we looked at baseline to final levels. There was trend data with intake of added fat of kids, but that did not reach significance. Okay, so let's look at the parent data. Again, we were interested in a couple of outcomes related to parents. The first was self-efficacy, or the confidence of parents in their ability to establish healthy eating behaviors for their families. And this is really where our strengthened findings were with the parent data. So again, adjusted for potential confounders, we saw a significant increase in all of these outcomes or parent practices, their self-efficacy in these parent practices. So participating parents were more confident that, for example, they could plan to include one vegetable at lunch and supper. They were more confident that they could cut up vegetables and put them in the refrigerator for their families. They were more confident that they could introduce low-fat foods to their families and meals and snacks. They were more confident in their ability to engage their children in meal preparation, and they were also more confident that they could introduce a new vegetable on a monthly basis. So one thing to mention here is that all of these parent practices that we identified that were incorporated in our intervention and we measured as outcomes have direct implications as it relates to a child diet. So that's sort of the weight of those findings. Okay, and then also, and this was really our strongest finding, which was encouraging because one of the main emphases of our program is to encourage family meals. But again, adjusted for potential confounders, we saw a significant increase in the frequency of family meals from baseline to the end of the project. Okay, so again,
I'm working on revisions to this paper right now. They're due Tuesday, but we're really arguing that our strongest findings relating to efficacy of program were in the parent population. And they sort of weakened when you looked downstream to the kids. Okay, so summary of results. Our needs assessment study, or our formative research, showed that parents value family meals, but we also discovered that they face multiple barriers. This was really consistent with what we already know, see in the literature. We also demonstrated that our program, our innovative evidence-based program, successfully engaged parents and their preschool age kids. So this was, again, points to the high feasibility and high acceptability of the program that we designed and tested. And there were hints of potential efficacy regarding certain child food preparation skills and diet outcomes, and also parent self-efficacy regarding healthy food and eating practices, and then family meals as a singular outcome. Okay, so where are we going from here? This research is really in its infancy. I mean, we've been testing this over the last 2 to 3 years, and we have a long way to go. We're excited about our paper that's coming out, but there's a lot of work that needs to be done in this line of research. So on a curricular or programmatic level, there's work that needs to be done in terms of the content of the curriculum itself and also the sequencing. So if you think back to for example, the dietary data we saw at the midway point, we saw a significant decrease in sugar-sweetened beverages, but that positive change did not persist to the final time point. Well, when you go back and you look at the curriculum itself, you'll remember that we did not have a singular lesson dedicated to that topic, and the messaging related to that behavior, sugar-sweetened beverage consumption, really came towards the beginning of the intervention. So it's things like that we need to think through. Like perhaps we should actually have a whole entire lesson dedicated to sugar-sweetened beverage intake, or maybe we should weave that message more heavily throughout the entire curriculum. Program dose is an issue that we're considering. We're actually right now just finishing up a trial where we're testing program dose. So for a feasibility, a community-based project, feasibility project, a monthly program dose is, acceptable. It worked for us. It gives you plenty of downtime between programming to go back to the curriculum, make revisions, and then come back out. We just finished a trial where we delivered the program on a bi-weekly basis. So once every 2 weeks, 3 months, and then we delivered monthly booster programs for 3 months thereafter. So that's really sort of the dosage, based, on what we know in the literature, that the dosage that works with regards to changing people's behavior in a community kind of program like this. I've talked about, the need for a potential booster program, and we're considering that now. Another thing that we're thinking about is, in order to affect the problem of childhood obesity in a significant and lasting way, we've talked about the value or wisdom in linking a program for preschoolers with other programs in the community that are targeting age groups that precede ours and come after ours. So as part of this dosage trial that we just finished this last spring, we linked our program, linked our program with the Moms to Be program, which the PI of that project is Pat Gabby. It's a similar program. The mechanism is the same as nutrition education and cooking. Their target population is different. They're interested in pregnant moms. We're interested in young kids, and so there was sort of a natural point of collaboration there. So that's something else we're thinking through. Staffing structure. When you're doing community-based work, something that is always on the back of your mind is program sustainability and how not just sustainability, but also how easily your program or efforts could be scaled up nationally. So We're now working, so you'll recall with this particular project, that our staffing structure included preschool teachers, students, and dietetic interns. And there is sustainability, some sustainability in that staffing structure, as preschool teachers are at all daycares, and there are dietetic internship programs all over the country, not just affiliated with universities. So in moving forward, we're talking about, and actually in an active sense, relying on the extension network, so the extension arm of the university employs individuals who are nutrition educators working in communities, and so we're now weaving in the extension network into our staffing structure. Program efficacy, I mean, this data that I showed today, I'm not fooling any of you, you're all empirical researchers. This was great data generated from this study here that will support the design of a larger randomized control trial, but we really need to establish program efficacy in moving forward, and that'll require a group randomized control trial. So we're revising an NIH grant right now to work on that, and scale up is always on our minds. Unfortunately, or fortunately, so there's a real need. As we've developed this program over the past 3 years, we've learned from the community, not just locally, but nationally, that there's a real need of daycare administrators and staff for a program like this, a program that combines parent-child learning together, that includes education and nutrition, but also skill building and food preparation skills. And so this program, Simple Suppers is the name of the program, has already begun to be replicated in a couple of communities within Ohio. And we just got off the phone last week with Kansas State, and then North Dakota State University is also, we're talking about scaling it up in other states as well. So it's encouraging, but as a researcher, we're not really ready to go there yet, but here we are. So we've also talked about in our future research expanding health outcomes. I didn't show you the BMI data, but we did collect heights and weights on these kids, which from those two pieces of information, you can calculate a child's BMI, which is essentially, an indicator of, it's a height for weight outcome, but it's an indicator of adiposity as well. So we did measure heights and weights as part of this program here, and we were measuring it in our current and future efforts. But we've talked about expanding our health outcomes beyond heights and weights and looking at measures, non-invasive biomarkers or measures of outcomes that precede excess weight. So we've talked about potentially collecting data on the gut microbiota, which there's a lot of research in that area, that an individual's gut, the microbiota, is related to their weight status and risk for other chronic illnesses, and that data can be, or that can be collected pretty easy with fecal samples. I won't go into this because you're not medical researchers, but this is another line of research that we're pursuing. Okay, so it takes a village to do this kind of work. I'm a young assistant professor. I'm just getting my feet on the ground. I've been really fortunate to have a great team of students and collaborators. This is my collaborator, Dr. Julie Kennel. She's the Dietetic Internship Program Director, and we've worked closely in the design and implementation and evaluation of this program. And then these are, again, we're interns, and then some of my students as well. And then Julie is not my only collaborator. Dr. Thelma Patrick, who's a faculty member in nursing, has been a close collaborator of mine, and she also does community-based nutrition work with pregnant moms. Dr. Pat Gabby, whose name I mentioned, Dr. Murray, who's here as well. The Schoenbaum Family Center has been really critical in helping us get our work done. And then I've listed all of my team members here. Research Associate Angela Rose, my two undergrads, Alan Wagner and Priya Patel, and then I have a whole new team over here this year. So Colin McGinnis is an honors undergrad student at Ohio State. Laura Berger is here as well. Alana's another honors undergrad student. Anna Brown is a new MS student, and then Katie Rogers is a new doc student of mine. And then I've also included our extension educator who we worked with in this last year. She's been really instrumental in helping us provide overall direction to the program itself. And again, she's an extension educator. So that was way over limit. Yeah, sorry, we made